Welcome everybody to the CIN webinar on how to prevent staff and provider burnout. This webinar will feature a conversation between a burnout researcher and CIN managing partner, and will explore strategies on how to address burnout and promote resilience. My name is Marie Hubbard, and I'm the project manager for the California Improvement Network, or CIN. CIN is a network of quality improvement leaders focused on innovation in healthcare. It's a program funded by the California Healthcare Foundation and administered by Health Force Center at UCSF. A few pieces of logistical information before we get started. Everybody will remain on mute except for our presenters. If you have any questions, please use the Q&A box at the bottom panel of your screen to enter any questions you might have throughout the presentation. We'll get to as many questions as we can throughout this hour. This webinar will be recorded. We'll be sharing the recording after the webinar once it's posted to the CHCF CIN website. So now I would like to introduce our facilitator, Dr. Sunita Mutha. She's a director of Health Force Center at UCSF, and she's also a CIN managing partner. And I will hand it over to her to get us started and introduce our presenter.
Great, thank you, Marie. I am really excited about this topic today and to be able to be with you, Rachel, who I'll get to introduce in a moment. This is a topic that I would say as a primary care clinician is top of mind frequently these days, both in our training setting as I think about the future doctors and other professionals that we're training, but also just in personally, in the challenges that I think we all face. And so I have some great questions for you, Rachel, that I'm curious to hear about. But you know, we know that we work in settings right now that there's just the tyranny of a lack of time, of knowing that there are the complexities of human interactions that occur there. We're balancing urgent and other things that we believe are less urgent, and we may or may not agree with patients that are receiving care about some of those things. So as we think about all of this stuff, we know that failure is part of this milieu, especially as we are trying new ways of doing work. And so the issue of burnout, which has certainly gotten lots of national recognition in the last few years, has become increasingly important, I think, to many of us on a personal level. So, you know, how do you think about it? How do we avoid burnout? How do we prevent burnout? This talk, I think it feels both personally resonates, but also just so important in the work that the California Improvement Network has really focused on in the last year. The consequences are not small. You know, we know that they're quite serious, so there are issues around burnout. We know that for clinicians, burnout leads to worse patient outcomes, which matters certainly to all of us, and that physicians in particular have high rates of suicide. And we have, we've seen a greater set of issues with that in the last few years in the trends. The good news, because there is some good news, is that I think we're getting much better at understanding the science of what's occurring, of how to measure burnout, how to think about how to prevent burnout. So for that reason, I think this is a very both topical and an important topic today. What I'd like to do now is, before we launch into talking about this, I'd like to ask Marie if you would launch our first poll, which is, we want to understand what are some of the reasons for those of you that are on today's webinar? What motivated you to take time to do this? So if you could look at your screen and go ahead and respond to those options. Okay, well, this is really interesting. So in thinking about reasons for joining today, it looks like the most common response, well, actually there's a three-way tie. I've observed providers in my organization who are experiencing burnouts and looking forward to that conversation. I've observed staff in my organization, equally important, who are also experiencing burnout. And then the other top one is, I'm curious about what other organizations are doing and thinking about when it relates to burnout for providers and staff. Less frequent are the other options, which is high turnover because of burnout, and also that I'm personally experiencing burnout. Great. So really interesting array, and let me go ahead now. I'd like to introduce Rachel. And Rachel, I would, as we have this conversation, I'm really going to be curious to hear your reactions to whether what we're seeing in this poll resonates with what your research experience has been. So for just to formally and officially introduce you, this is Rachel Willard-Grace, who is director of the University of California, San Francisco Center for Excellence in Primary Care. She began her career, interestingly enough, as both a medical assistant and a pharmacy technician, and then later worked as an executive director for a free clinic in Texas, as we were discussing earlier. She conducts research that's related to burnout, to health coaching, and looking at primary care transformation, and topics that actually really come quite well together in ways that I think you'll just share with us. She also guides the Center for Excellence in Primary Care's extensive training programs. For those of you that are interested, there are resources at the end and a way to contact Rachel for questions that I know will arise. So Rachel, with that, I am going to go ahead and hand this to you to share with us what you've learned, what we know.
Thank you so much. I appreciate that introduction. I'd like to talk today on two levels about the issue of workplace success that we know by a host of names, Joy, at the Center for Excellence in Primary Care in this regard. Before I step into either of those, I actually want to go back about 20 years to one of my first days at the free clinic where I was working. And I want to describe, I want to give you a little bit of a snapshot of my first taste of healthcare. So within, I'd say, the first 2 days of my presence at this free clinic, I realized that we were in the midst of a crisis. There were staff, volunteers, patients, people felt like the others were undermining them. They felt overwhelmed by the need that faced them. They felt overwhelmed by the lack of resources. There were lines around the block. There was a tremendous need, and there was a sense of just emotional overwhelmment. At one of our first meetings, several key members of my staff threatened to quit. And I was at a complete loss. And without understanding what else I could do, I asked people if they would be willing to share a little bit about what brought them to the work in the first place. Very talented people. They could have made more money somewhere else. They could have had shorter, more contained hours. They could have had less stress, but they chose to be where they were. And what came out was beautiful stories about the connection to the work. Many of them had past personal experiences in which others helped to lift them up. They wanted to be doing the same for others. They saw the profession in which they felt they could do the most good. What they experienced on a daily basis was often feeling as though they were at odds with the very people that they were there to help. They felt as though they were the environment in which they were present was not allowing them to experience the opportunity to offer the help that was so meaningful to them. And I didn't have a vocabulary for their experiences at that time. What I encountered may have gone by the name now boulders in the path. We were able to start chipping away at some of those and reconnect people to both the work and to the clientele that brought them there in the first place. So I have the privilege of working now at the Center for Excellence in Primary Care, where our mission really is to identify great practices that are currently taking place around the country, to develop those into systems that can be scaled, to test them through research and evaluation, and then to share many of those innovations. These are largely innovations that are intended to improve the patient experience, enhance population health, reduce the cost of care. Many of you will recognize there what we often think of as the triple aim, and to restore the joy and satisfaction in the practice of primary care. And so you see that embedded within our mission statement. I'll mention that our website is at the end of this. I'm going to linger on that for a moment. There's a lot of free resources. Please feel free to access those or to contact us if we can be of help. So first, I want to offer a little bit of a framework for thinking about work experience, joy, and practice burnout. There's been a movement over the last few years to really move from what we just referred to, the triple aim of cost, population health, experience of care, to also include a fourth aim around the experience of the people working within the field of healthcare. One of the drivers of this is a growing recognition that burnout is a problem within healthcare. So this was one spark for this was a study that came out in about 2012 by Tate Shanafeld and colleagues, where they were looking nationally at a sample of physicians trying to compare their burnout to the general population. And for reference, the general population, they would find a there we go. So as we think about burnout and the response to it, there have been varied attempts to address this. And I find it really helpful to think of this in terms of this wheel, in which you'll see there's culture of wellness, personal resilience, and efficiency of practice as ways in which to think about burnout. And so let me briefly describe what some of those interventions tend to look like. That first slice of the pie at the bottom, and this is a model that came out of a group of Stanford researchers that do a lot of work in this area. I find it very helpful. The bottom is really thinking on the personal level. So this is things like your mindfulness-based stress reduction programs, cultivating compassion, cultivating gratitude. So it's thinking on the personal level, how you process your day-to-day stress and how you respond to that. And then we can think about things like a culture of wellness. And here we're talking a lot about organizational values that promote self-care, professional growth. We think a lot about the role of leadership as we think about a culture of wellness and what leadership can do. A lot about cultivating community. One great example of this, just to give you a picture of this, that I really appreciate was a study that was done at the Mayo Clinic, in which physicians were randomized to either get an hour every other week of time during work to do whatever they wanted to do, or an hour to have a discussion with their peers. And these discussions really focused on the meaning of work. So there were things about difficult encounters with patients, about death and dying, about mistakes, about the joys that they experienced as physicians as well. At the end of that period of time, they found that group that had been randomized to the discussion felt a greater sense of empowerment, a greater engagement, lower sense of depersonalization, which we think about as kind of emotional distancing from the work, and a greater perception that the work was meaningful. That final slice of the pie, this takes a moment to load. We'll let the slides catch up to us. That final slice of the pie is what we think about as efficiency of practice. This way. Becca, I'm having a bit of trouble advancing. Are you able to advance that for me? Thank you. One more, if you don't mind. If we think about efficiency of practice, a lot of times we're talking about things like designing waste out of a system, or about designing teams that share responsibility for patient care and things like documentation. Go ahead and advance if you don't mind. I had the privilege a few years ago of taking part with Christine Zinsky and others in a search for practices that were really excelling, that were known as places where people wanted to work. And we were looking at some of the practices that were most meaningful to the clinicians in those settings. So we had identified 23 practices across the country. This is a bit of a quick map. As you can see, they sort of scan a lot of the country. And a lot of the activities that fell into this, that we were looking at, really fell into this particular swath of trying to improve efficiency of practice. So some of them were things about reducing waste. There was just a lot of waste that happens in healthcare. you follow medical assistants around and just count the number of trips they make down the hall to the printer or out to check and see if, in former days, out to see if the patient was there. We spend a lot of time playing phone tag. We spend a lot of time chasing down patients with things like, INR results, rather than taking advantage of that face-to-face time of being able to have that conversation on the spot. A lot of that sort of barrage of prescription renewals, a lot of time faxing documents, a lot of time logging on. So there are things like this, and this often falls into kind of this pebbles in the shoe category of things that these practices were systematically doing to try to take those pieces of waste out. One very popular area for clinicians in particular is thinking about things like team documentation. And so this is also known as scribing, but it's really talking about having an additional team member in the room or virtually who is putting in orders, taking pieces of the medical history, and allowing the clinician to be face-to-face with the patient and to finish the notes more quickly. So we think about, again, that added efficiency. We also think about expanded roles for non-clinicians. So we talk a lot about expanded rooming protocols, standing orders, integrated behavioral health, and pharmacists. So before we move too far into our work, I'm going to take a pause, and we're launching another poll because we are curious about which of these slices of the pie are of greatest interest to you. And feel free, Maria, to go ahead and launch that poll. So you'll see that pop up on your screen. Which of these domains, the culture of wellness, personal resilience, or efficiency of practice, are of greatest interest to you at your practice? Now, as we take that poll, we're also going to take a few minutes and just open this up for questions before we move on to the work that we're doing at the Center for Excellence in Primary Care. So feel free to type your questions into the box, and Maria will be sharing some of those. So we'll take just a couple of minutes before we move on.
So just as a reminder to everyone, if you can use the Q&A function at the bottom of your screen, or the chat function is fine as well if you're more familiar with that, to share any questions with us. I'll also apologize, we're having a bit of internet connectivity issues, but we appreciate your patience as we get through this content.
So it looks like many of you, 50% of you, described culture of wellness as being of top interest to you. Efficiency of practice coming in second at 43%, and about 7% describing personal resilience as being an area of focus. So that's fantastic to hear. So many of the things I'm going to talk about in relation to our work fall into this efficiency of practice, but let me try to take a few minutes at the end as well to describe a few other practices that have really stood out to me around that culture of creating a culture of wellness. So I appreciate that. Thank you all.
And we do have one question, Rachel, if you want to take one at this time.
Absolutely, please.
So the question is, how can an organization or even a department within an organization promote self-care? What kind of tactics or ideas do you have around that?
You know, it's interesting that you asked that. I mean, I see a lot of different practices that range from, for example, offering some access to programs around, gratitude or self-care or things like that. I know that someone who does a lot of this work with the AAFP was really saying that they had a huge surge of interest in that kind of self-care packages. And I've mentioned, for those of you in family medicine, I'd certainly look to that because they've tried to create some tools in which you can kind of create some self-care goals and trying to create some community around those. There's, everything from the, getting out together to go walking to trying to build in time for the things that are important to one personally. I think that those kind of programs, in my mind, have the greatest impact when there is some degree of organizational investment and encouragement in them. It's a little bit hard if there's not, I come from the public health background, so I'll always look at this from that lens, that we always think about change being most powerful when you think both about the personal level and the environmental level. I become a little bit concerned when I only see that interest on the personal level, because there are often very real environmental factors that are related to that. So I think that many times that best sort of magic formula is often that combination of clearing barriers from the organizational level and then encouraging that sort of group movement towards self-care on the personal level. But I do think there's a lot of interest and a lot of value of self-care type of activities. And I think people have had some very good experiences with those. Maria, any other questions for the moment before we can jump into the next section?
None at the time, so feel free to jump in.
Super. Great. Well, let me tell you a little bit about our work. And again, many of the things I'm going to describe are going to fall into the that area of efficiency of practice, into secondary degree, into the culture of wellness. I do want to preface this by saying that much of our work has used the language of burnout. And I think that that construct is related to this nexus of concepts around joy and practice. I want to say up front, I don't think that burnout in certain ways is an end, addressing burnout in certain ways is an end in itself. I think that it is in a lot of ways, it's a helpful barometer. I think of it a little bit as a canary in a coal mine. When you see it surge, look at the environment and try to understand what's happening in the environment. We are, as a research world, a little bit at a loss as to the best tools to measure things like joy and practice and meaning. This is one way we've tried to get at those concepts. But I do want to encourage you not to limit your thinking to burnout, but think more broadly about meaning and connection and joy. Many of the things I'm going to describe come from our work in the System Transformation Engagement Project, with the STEP survey. This is an annual survey we've been conducting since 2012 of clinicians and staff in 2 to 4 health systems, depending on the year, across the Bay Area, often somewhere between 16 and 25 clinics represented. We have included measures such as the Maslach Burnout Inventory, which is one well-recognized measure to look at burnout, things such as the team structure or team culture, look at support for social needs and behavioral health. We've often used measures such as pulse. Many of you recognize that friends and family question about the likelihood to recommend your clinic as a place to work. We've had a lot of other revolving topics around capabilities for new roles in healthcare that have also been part of this. Many of the analyses I'm going to describe, with one notable exception, are cross-sectional, where we're kind of looking at the relationship between some of these factors controlling for things that we know impact it, such as the length of time people have worked there, and other factors like that. But I won't get it too deeply into the analysis right here. So the first one I want to actually land on is a word about burnout measures, because many people do approach us asking about burnout measures. And I want to give you a little snapshot of one of the things that we noticed. So first is a little bit of background. This is a study that came out in 2009, and it was looking at, used a one question about burnout, where people rated their own burnout from a scale of 1 to 5. And this study found that in their national sample, about 33% of clinicians were burned out. A few years later, that famous paper came out from Tate Shanafelt and his team, which they used the Maslach Burnout Inventory, and they defined burnout as ranking highly on either emotional exhaustion, feeling very tired from the emotional interactions, or depersonalization or cynicism. So that would be kind of the emotional distancing from the work, feeling that your work doesn't matter, that doesn't make a difference. And so in their estimates, they found that 45% of physicians were burned out, and that again, going back, that was higher in primary care. So what do we do with that? Did burnout actually go from 33% to 45% in a matter of a few years? Well, probably not. So our own study, we actually used, in the recent year, we used both measures. And just to give you a picture of this, so if you look at the far left, you're looking at clinicians reporting exhaustion or cynicism. That's the 52% that you see here. You see the percentage who are reporting exhaustion and cynicism. There's a lot of overlap, but not everyone who reports one reports the other. And then down at the bottom, you see that single item measure of burnout, that one question, how burned out are you? And you can see same clinicians, same point in time, same survey. You have estimates of 52% or 29%. So what does that mean if you are interested in this topic? I think what we would urge from that is use the same measure consistently, because if you're trying to track it over time, don't switch your measures because you may end up with something a little bit different, and be careful who you compare to and that they're using the same type of measure. I often hear people, use a single item and just say, well, things aren't so bad in our organization. And I think what the important thing is to compare it to like measures. Either measure is valid, either measure has utility. There are compelling reasons to use one item rather than 22, but just realize that there are some different estimates. A lot of our work has been connected to, focused on what the associations are with burnout. So let me give you just a couple of pictures of that. So again, here we're looking at culture of wellness, things like leadership, values alignment, community appreciation, and then efficiency of practice, things like the team-based care, EHR proficiency, and documentation. And I'm just going to give you a very small selection of the studies that we've looked at. First, let's focus in on team-based care. So one of our questions was around the structure of teams and the functioning of teams. And really the question was, are those related to burnout? So again, within that STEP survey, we talked to about 700 folks. And for the clinicians, we're just going to focus on the clinicians and not the staff here. If you look at the group that reported low team culture, so this is the people that did not agree with statements such as, we work well together as a team, I can count on other people to do their job well, we manage change well as a group, we address things. It didn't really matter what you did with the team structure. So whether people said they work with different clinical partner every day, they work with a small number of clinical partners in what we call a team, or they work with the same partner almost every day, you really didn't have much difference in their the reported exhaustion. Now for that group with a high team culture, the story was very different. So here you see those that reported working with a different person every day, no team, they had the highest exhaustion, and then gradually on down to those working with the same clinical partner almost every day who had the lowest exhaustion. And so what we really see here for clinicians was it was sort of this mix. The tight team structures, working consistently with the same people, were very valuable if the culture was also present. So I think it's a reminder to us that teams matter, but that you can't simply put people in the team and call it a day. There's a lot of that soft work that happens there. Another topic that I know the CIN has been a lot of time talking about is thinking about behavioral health and social needs, the building capacity for that within primary care. So the next item I want to show you is related to that. So here this particular example, we did both with the SEP survey, and then we looked at a national sample through the American Board of Family Medicine, and used their board survey to examine this question again. So the data I'm going to give you are from the board survey, which is a different population, but this was a similar pattern that we saw in our own survey. So we were really looking at that capability, the question, does your clinic have the capability to address the social needs of your patients? And for those that reported a low capacity for addressing social needs, there was about 30 to 35% burnout, depending on whether you were looking at clinics that reported the low percentage of vulnerable patients versus those that reported a high percentage. Now, for those that reported high capability for addressing social needs, the story was quite different. So here you saw about 20%, and it didn't really matter whether you were looking at that setting with high proportion of vulnerable patients versus not. Having that support for addressing social needs mattered a lot. And so we've talked about burnout and some of the potential factors that we would imagine lead to burnout. The last study I want to share is in relation to what might come of burnout. So we think that, for example, burnout may be associated with retention, with quality of care, with patient experience, with other kinds of system outcomes. Some of these have greater evidence than others. One of the examples in the case of retention and turnover, there actually have been relatively few studies that have been done longitudinally and have looked at how likely people are to leave. A lot of questions talking about retention and turnover actually use people's prediction of whether they think they'll leave within 2 years, which also reflects a lot of other feelings about the job at the time and doesn't necessarily predict their likelihood to be gone in 2 years. We had the opportunity, because this is a longitudinal survey, we had the opportunity to look at what burnout looked like in one time point, and then 2 to 3 years later, look and see if people were actually still in the systems. So here I'm going to show you a little bit about the unadjusted results for our clinicians and staff who reported not being burned out. We had about 25% for clinicians, about 40% of staff had left after 2 to 3 years. And if you looked at the proportion who reported being burned out, this is using the Shanafelt definition, high exhaustion or high cynicism, the proportion of staff over on the right was about the same. It didn't seem to matter. For clinicians, a greater proportion had left after 2 to 3 years. And when we adjusted that and clustered, that was also significant. So what are the future opportunities for research? We are currently trying to link some of this data to quality indicators such as HEDIS measures, to looking at CAHPS data around patient experience. We've been working with folks around connecting it with objective and subjective measures of EHR proficiency and workload. So I think these are several other important areas that would align with what many people think about when they think about burnout. And I'm just going to pass right through this and go to resources so we can move on with the discussion. But I do want to highlight, we've got our website here. Please access that and avail yourself of some of the resources that are there. And please use it to contact us because we're more than glad to share additional resources as we're able. I also want to point out that IHI, the Institute for Healthcare Improvement, has a large initiative on this topic. I've listed the link there, and that the American Medical Associations created the Steps Forward program that, again, really focuses on this. And I also have my contact information here as well. So with that, let me go ahead and hand this back over to Sunita to start a discussion.
Yeah, well, this is great. Thank you. What I particularly appreciated so far, Rachel, of what you've shared is this framework which says the responsibility for burnout doesn't need to burden the individual, which I think sometimes that gets lost in the conversation, and you'll sometimes hear. So I'm thinking of my own practice setting, and I'm thinking of the residents that we train, and the frustration that gets expressed when they hear, well, you know, you should just take care of yourself, like as if the responsibility then lies with the individual. So I appreciate that there's a framework that says that there are 3 main components to this. The individual is a portion of it, but it's not just about the individual.
Absolutely.
The question I have for you, so on every one of those, we have primary care at the top. Why is that? Why does somebody who practices in a primary care setting, why is their burnout rate, the rates of burnout seem to be so much higher?
That's a great question. And I think that what a lot of people in the field tell us is that the pressures are increasing, both by movement toward greater management through electronic medical records. A lot of work has sort of reverted to clinicians, but also that the expectations are increasing. It's not simply about screening for depression anymore. It's about lowering scores for depression screeners. Not simply enough to be measuring colorectal cancer screening, you have to move the indicators. Not enough to talk about the patients who come to your practice. You're talking about your whole panel, that movement from thinking about where your responsibility lies. So for a lot of folks working in this field, it just feels like more is being added. And I think that's a legitimate concern, and one that many times practices have to really connect over as they redesign practices.
Great, thank you. I'm also curious, the data that you've shown so far doesn't indicate that, but or address it, but I wonder if you could share what information you have. Is there a generational difference in this? Like, do we know that younger physicians experience burnout differently or don't experience burnout than those of us that have been in practice longer?
That's a tricky question to answer in the health system. And the reason is that we know from the literature that burnout tends to follow a U-shaped curve. So often we have a height of burnout early in career. People who don't feel that that environment is good for them drop out. They leave. They reduce their hours. They leave practice. So we have a drop in burnout, and then it gradually increases over time. Within some health systems, one of the things I've noticed is that many times people who have been there 5 years or more are actually doing a little bit better. And sometimes I think what we're talking about is the people who really were able to thrive in that environment and who continue to do well there.
So are we just selecting out and keeping those?
There's always that danger. I think would be, I think some of the national data would be probably a better place to think about generational trends. In particular, some of the data sets that are looking at people across their career path and not within their career path within one organization.
So I'm curious, I'm thinking, of course, of my own experience, and I'm thinking about those of us that do clinical work of whatever clinical background we have. So as I'm in practice, and if I am concerned about my colleague or myself, and I'm trying to do an inventory without having to do surveys, what are the symptoms I should be thinking about to say, gosh, you know, there's a risk here, or I am in fact burnt out, or my colleague is burnt out?
That's a great question. And I think there certainly are brief measures that would allow you to kind of assess that, as we do for things like depression or things like that. However, the way I think about it most simply is that many of us enter a profession knowing we're going to have to wade through mud to get to the goal. When we stop being able to see the goal because we're just surrounded by that sense of inadequacy, of struggle, then I would say that is very much on my mind. When I hear people talk in those terms, where they're not talking about the vision, they're not talking about the connection, they're not talking about the good that they're able to do, they're just mired in the day-to-day struggle. That's where I tend to worry about it, just without ever administering an instrument.
Okay. So taking the pulse in that way and thinking about whether or not we're able to keep that larger vision, that longer term vision.
Absolutely. So I think it's important to separate the idea of challenge and struggle from the idea of being beaten down by that. I think most professions have some level of challenge and struggle. Sometimes that's wrapped up in the same things that attract us to the physicians. The chance to be, the lack of support may also be manifest as the opportunity to do every job that's very attractive, that draws some of us to different work environments. But it's where people start being beaten down by it that you begin to worry.
I have a couple more, and then I know that we want to leave time for others to ask questions. So I'm trying to prioritize which one. Let me ask you this. So if we put ourselves in the shoes of the leaders, and we are talking about being responsible, caring for all of these individual clinicians and staff, which I think that data are really powerful, that the impact is spread across everyone in this environment. If I could do one thing as a leader to prevent burnout, what would you, based on the data that you have, what would you say I should prioritize?
I would say there's evidence that there's strong value in the leadership presence and being listened to and knowing that leadership is fighting for the things that matter to you. I think that there's evidence that when people we know that related to that culture of wellness, we know that when leaders understand the passions and strengths of people and they're able to put them into some of the roles that match those, there's increasing level of wellness, decreasing burnout, up to about 20% of their time. So part of the message is that people don't necessarily need to spend 100% of their time doing what they care most about. but they need some taste of it. They need that experience of connection. And so people are willing to do a lot of other things if they can also have that connection. I think that there's also real importance in leadership understanding what the pebbles are, what the boulders are, seeking to be responsive to the pebbles as quickly as possible, and then sharing the journey of trying to chip away at the boulders. I think that one of the things that we're starting to move to when we think about leadership is that leadership understands my struggles and is seeking to improve them. And my hunch is that that's going to be a very important measure for engagement and for continued passion for the work, just knowing that someone has your back.
Thank you. I want to be thoughtful, Marie, to see if we have questions that are being posed. Otherwise, I will continue asking.
Yeah, we don't have any questions, so I would say continue asking. And just as a reminder, again, for those on the webinar, you can use the chat function if that's better for you, or you're welcome to use the Q&A box.
Okay. Let me ask you a question that I think that the first time I heard about burnout came up early on, which is, what evidence do we have, or how do we address when the discussion ends up being it's a bunch of people, fill in the profession, staff, clinicians, who are sort of self-indulgent. They are expressing things that are just frustration of the normal change. Like, how do we know burnout is a thing as opposed to a blip, or that we're measuring something that's always been there, but now where it's getting heightened awareness? How do you respond to that sort of comment?
And as I'm listening to you, I'm thinking this is sort of a reaction that's coming perhaps from leadership to say this is not, or from external people saying this is not really an issue. You're just starting to create an issue by measuring it.
Yes.
Okay.
Yes.
I think that we do have some indicators over time that there are increasing pressures. We do have some of the work that's done nationally to show that some of these indicators have gotten worse over time. I think that we know, I think one of the other factors is we know a lot of people are leaving healthcare, and that is a big concern. We need that workforce. We need that institutional knowledge and wisdom. We don't want to lose people from these professions. We don't want to lose medical students or residents in the midst of their careers. And so I think that that is also an indicator that's hard to ignore. I do think that when you measure something, you do tend to put a spotlight on it. And I think that one of the reasons I would be eager to find additional measures is because I think that it's helpful sometimes to pair that barometer of the challenge of the work and of the feeling of being beaten down by the work with something that is really a positive goal. So I think that I'd love to see more indicators for practices that focus on meaning, that focus on connection, that focus on being able to advance the mission that brought them into the field, because I think that would really help us move the conversation forward as well. Great. Thank you.
And we do have a question from the group, and I think it's pointed towards you, Rachel, but Sunita certainly chime in. So what else can you share about the connection between organizations addressing social determinants of health and lower burnout? So in other words, is there a tipping point of how much an organization is addressing social determinants of health, or do even small investments in social determinants of health pay off in terms of lower burnout?
Yeah, that's a great question. Our work has largely focused on responses on clinicians' perceptions specifically of the availability of those resources. And so we have not looked at the actual staffing ratios in relation to the need. And I think that would be a fascinating area of work. What we do know from our work is that those practices that report a high capacity are more likely to have social workers and pharmacists on staff. And the pharmacist was kind of an interesting factor to me. But there is a perception that there are certainly certain kinds of roles that are particularly critical to advancing work. But I think that's an area that does merit more research.
So when you think about interventions,
Mhm.
because we've talked about a couple components. We've talked about how do you prevent it to begin with, and then the interventions to address it when it's occurring.
Mhm.
Which intervention excites you the most? What do you look at and say, I'm curious to know what our research is going to show or how this might play out?
I will mention that there's a number of initiatives by the American Medical Association that they're investing in right now to kind of invest in some of these steps forward practices, such as shared inbox management, bundled prescriptions, things like that, that they are able to look at on a broad enough frame and in a coordinated evaluation strategy to be able to look at the impact on people's work experience. I'm very excited to learn what they find through that, because I think that's a very promising initiative. I think it's something that if you talk to clinicians, and they would be very excited about many of those movements. And so I think that that's one. I do think team documentation or scribing to me is a very fascinating area of growth. It's been typically very difficult to study because often scribing is either provided to people who are struggling with their documentation, or alternatively to people who now have a greater expectation of productivity. And both of those can kind of have very different experiences. So I think that it is a fascinating, very promising opportunity that is, thus far, I haven't seen a lot of really studies come out where they have really been able to do it in a systematic way to understand its immediate impact. But I do think that's another really promising area. I think that is a stopgap measure. I think that ultimately what many of us dream about is EHR that better reflects the needs of the care visit. But I do think it's an important interim measure to protect the clinicians, and has the added benefit of pulling staff into the encounter, which is where many of the staff are so eager and so hungry to be.
I realize I have two sets of questions for you that are very different. One of the things we haven't talked about all in here in an active way is, what is the role, if any, of the patients?
Great question. Yes.
Right? And because we're talking about systems, we're talking about the clinicians, the staff. And then, of course, a big component of it is it's all wrapped around, we hope, around the patients. Who both deserve excellent care and are come in seeking care.
Absolutely.
So what have you seen that sheds a little bit of light on what, if any, role in a part beyond the fact that we want them to not have burned out providers and we want them to get excellent care? Is there a role for patients?
That is a great question. I have not seen anyone asking that question in kind of the research intervention world. I think that what is coming to mind when you say that is a study that was done in Canada around the priorities, community development of healthcare priorities, and how those conversations shifted when patients were part of the discussion. And one of the things that really stood out to me from that study was that many of the patients were in fact advocating for their providers and saying, for example, yes, I want more access. I want to be able to come after work. I want to be able to come on the weekend, but I don't actually want my doctor to have to not go home to dinner with her family. And so the conversation really shifted by virtue of bringing those two discussions together. I think it would be fascinating to understand what happens with some of these discussions around interventions into burnout, promoting joy in practice when you bring patients to the table as co-designers and as people with deep expertise within the medical system.
I'm also curious, unless, Marie, we have a question we need to turn to. Great. I'm curious, so we're talking about interventions that cost money.
Yes.
Right?
Yes.
Whether it's scribes or EHR changes, all of these things. So how do you help leaders think about this issue when we're talking about there's a cost to burnout or to lack of joy, and that these interventions take money? How do you, and yet the pool of resources that we have is finite.
Yes.
Right? And we already say healthcare takes up a whole lot more of our GDP than many of us probably feel is appropriate or right.
Mhm.
So, so as you have conversations with leaders about this issue, how do you help them think about the investment in addressing these issues, in addition to whether it's new technology or EHR upgrades
Absolutely.
or staffing?
Yes, absolutely. You know, I think one of the things I would first just talk to them about is what they're already investing in the issue of burnout, not by preventing it, but by its cost to them. And I think there's actually a lovely paper out about what leadership can do to address burnout that was put out by Tate Shanafeld and colleagues. I think it's a great resource. I highly recommend you go to that. And one of the things it provides in one of the boxes is a calculator of what your turnover costs actually are in a dollar amount. So if you could reduce the turnover of one MA or one clinician, what money would that save your organization? And could you proactively view that as an investment to try to reduce that turnover? So what would you pay in recruiting costs for your MA pool versus what would it cost to try to create a program of flexible work study? What are your costs of replacing a provider versus what would it take to start to tackle some of these issues around prescription bundling or things like that? So just a few thoughts, but I think that it's nice to open people's eyes to what they're already spending before you start the discussion about the costs of the program.
The additional costs.
Before we wrap up, Rachel, can you just repeat the name of the study with the calculator for cost savings that you've referenced?
Well, I'm trying to remember where it was published, but it is a study by Shanafeld and colleagues, and it's called, if I recall, the clinician, leadership. I want to say it's called What Leadership Can Do to Address Burnout. I can certainly share a link to that if you all have any kind of circulation, I can pass that on, as well as some of these other links to some of the Steps Forward curriculum and the IHI materials in our own.
Yeah, that'd be great. Thank you.
Do we have time for another question or two?
Yes, we do.
Okay. Which one do I want to ask? Well, you know what? I want to ask you a question. So you've been doing this work for a while. You've been leading this effort. What is it that energizes you about this work? I'm curious.
That's a great question. I think ultimately, when I was working at a free clinic years ago, much of my responsibility was in finding funding for the clinic and helping to start new programs and helping to iron out issues around prescription acquisition and things like that. And what I found was necessary to keep my sanity was to leave my office every day and walk through the floor. Just spend some time checking in patients, spend time talking with people about their stories, spend time interpreting. But it ultimately, I think, is the connection with patients that can drive our excitement about the other tasks that have to get done in order to reach the goal. And I would say there's a lot of similarity. I have the privilege of in addition to this work, of doing work on various clinical trials. So I get to meet many of the patients that are served by the clinics that we also engage with around the STEP survey and other opportunities. And I think that is ultimately the source of the joy. It's an understanding, hearing people's stories, realizing what amazing care many of these clinicians and staff are providing to people, and then trying to find ways to support that work.
Great. Thank you very much. This was informative. I think it's just so helpful, Rachel, that the work that your organization's doing to help take frameworks, bring them forward so that everyone knows that they exist, to think about thoughtfully about measures where they can be useful, where they have some limitations. So I walk away with some practical things to think about, and I think really helpful to know about some of the resources, particularly the idea that we can calculate what the impact is, because I think that makes for a more meaningful conversation and also a way to try to influence and persuade others. And the part that I'm probably struck by the most as we think about this is, so much of the work that we do at Health Force really focuses on the workforce. It focuses on capacity and distribution. And so it brings this issue of the loss that occurs when we lose people from practice. That makes me probably even more concerned. We're already talking about shortages and maldistributions, and the notion that we could lose really important people raises my concern. But I have hope, which is balanced now with some of the things that you've shared. So thank you for that.
Oh, my pleasure. Absolutely.
I look forward to perusing those resources in a bit more detail, including the calculator.
Very good. I will be sure to share those.
Yeah.
Thank you.
Thank you.
So before we wrap up, I'm just going to launch a final evaluation poll. Please do that. It helps us better understand how we can improve these technical assistance opportunities for the quality improvement work you all are doing at your organizations. So again, this webinar was recorded and we'll be posting that on our website in the coming weeks. For other technical assistance opportunities, including a CIN Connections report that was released in February 2018 on this exact topic, and other webinars, they're available on CIN's website, which is www.chcf.org/CIN. Thank you all so much for participating today. We're looking forward to seeing you all on future webinars.
Thank you so much.
Oh, my pleasure. This was a lot of fun. Thank you.